good. So let's start with part 2 of our follicle monitoring series. But before starting with the why of follicle monitoring, let's discuss the basics of female infertility. So if the cause of female infertility is like ovarian, okay, then we have to treat it via ovulation induction, where we tend to give ovulation inducing drugs, or we can say drugs to increase the number of follicles developing in the ovary and then helping them to ovulate for 3 to 6 cycles. If that fails, then we tend to combine ovulation induction with IUI for another 3 to 6 cycles, and if that also fails, then we tend to take the patient for IVF. Okay, so these anovulatory disorders are classified into 4 groups. Group 1 is hypogonadotropic hypogonadism. Okay, the next group 2 is eugonadotropic eugonadism. The group 3 is hypergonadotropic hypogonadism, and the group 4 is hyperprolactinemia. Okay, so these are the 4 basic groups of the anovulatory disorders, and we have to treat each one of them accordingly. So like for group 1 disorders, we tend to give gonadotropins or pulsatile GnRH therapy. Okay, for the second group, like PCOD, we tend to give clomiphen citrate and letrozole. For the third group, hypergonadotropic hypogonadism, for example, there is premature ovarian insufficiency. The ovaries have failed. So here the only treatment available is ovum donation. And the fourth group is where prolactin is increased, which in turn causes reduced levels of GnRH. So we give bromocriptine or cabergoline to decrease the prolactin level, and which in then turns corrects the GnRH levels in the body. So these are the 4 groups of anovulatory disorders and their treatments accordingly. So these drugs actually work via increasing the development of follicles. Okay, so let's say I have treated one patient of infertility with ovulation induction, giving ovulation inducing drugs like clomiphen citrate or letrozole, or injectables like gonadotropins for 5 days, like from day 5 to day 9. And then we ask the patient to undergo follicle monitoring, regular follicle monitoring. The dominant follicle develops. Ideally, it achieves 18 to 20 or 20 to 25 mm size. Then we can ask the patient to undergo timed intercourse, or we can have ovulation trigger, where we give injectable drugs like injectable beta HCG drug, IM injection, to trigger ovulation. After this injection, approximately 36 hours after this injection, ovulation occurs. And accordingly, 36 hours after this injection, we ask the patient to come and undergo IUI. So this is the whole process of ovulation induction for 5 days, follicle monitoring, ovulation that can either achieve naturally or with the help of ovulation trigger injections, and accordingly we ask the patient to undergo IUI 36 hours after the injectable ovulation triggering agent. Okay, so if this also fails, then we ask the patient to undergo IVF, in vitro fertilization. So what we do in vitro fertilization is, first of all, we cannot rely upon the normal natural development of follicles. So we give ovarian stimulation via injectables. So like in natural cycle, there is only one dominant follicle, but when we give injectable drugs, there is ovarian stimulation, controlled ovarian stimulation, and we have multiple ovarian follicles. Okay, when we have multiple ovarian follicles, like 18 to 20 follicles developing in each ovary, we give the patient ovulation trigger like injectable beta HCG, and after this trigger, 36 hours after this, ovulation happens. So then what we have, we retrieve these follicles. Okay, by the help of TVS probe and syringes and needles through it, we tend to see the needle through the follicle. We tend to retrieve this follicle. Then in next, what we do is we culture this ovary and sperm, get the zygote in an artificial culture media in a petri dish, where we tend to have this embryo. Then the embryologist just sees this embryo, whether it is growing or not, and then we transfer this embryo in day 3 or day 5 via catheter into the uterine cavity. So this is the whole procedure of IVF, ovarian stimulation with injectables, then giving the trigger for ovulation, then retrieval of these eggs, then in the petri dish fertilization of eggs with the culture of embryo, and then finally embryo transfer. So we understood the whole process of the whole game of infertility is to track these follicles. Where is the role of the radiologist? The role of radiologist comes in tracking the follicular growth and make the fertilization happen once ovulation happens. So this is the whole crux of female infertility, where we radiologist comes into play. So now let's discuss the why of follicle monitoring. Thank you.